Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. You see the ground rules here. I won't go through them. I think people know them by now. And closed captioning is available. The session will be posted later on YouTube. And if you have questions, please type them in the Q&A box. Let me move forward here. Okay, so today is a clinical problem-solving case. Just a program note with the Chancellor's announcement that people will be returning to on-site work, or many people will, as of March 1st. We're taking a look at that, and we will plan on beginning in-person grand rounds. What a thing. Sometime in March. We haven't figured out exactly what the best date to start will be, but we will let you know. And when we do, it'll be in the brand new, beautiful conference room in the first floor of the C building at Parnassus. We will continue to broadcast it live, continue to post it on YouTube. So you'll have a lot of different options about how to watch it, but I hope to see some of you in real life, which would be kind of fun. Next week will be another COVID grand rounds, topics TBD. I'm sure we'll cover something about the new variant of Omicron, something about a fourth shot and a booster, something about whether we are in endemic mode and what that means, and a few other things. Today, thrilled to do another clinical problem-solving case, this time with Lisa Winston. I will moderate it. The case was selected and prepared by Fangdi Sun, who is our wonderful chief resident, and I'll introduce our discussant a little bit later. So just the ground rules for the clinical problem-solving cases. You probably know these if you've attended some of them, but our discussant has not heard or seen the case before, does not know what is coming in the case, which makes this a little bit of a high wire act. The goal is to see how a master clinician thinks about a challenging case, and to make clear sort of the twists and turns and how you process new information as it comes in the face of substantial uncertainty. The goal is not to get it right. It's nice if they do, but it's not the main goal here. The main goal here is to learn something about clinical reasoning and problem solving. Our discussants aren't magicians, and I think one of the points is you don't have to know everything, although it helps to know something. And it's about the journey, not the outcome. And we hope you will participate along. There are a few audience response questions built in, but even without that, try to see how you're thinking about the case as well while we go through it, and hopefully this will be fun. So before we start, let me bring on our speaker, our discussant. It's Lisa Winston. Lisa is professor of medicine at UCSF in our HIV, infectious disease and global medicine division based at Zuckerberg San Francisco General Hospital. She is the chief of staff at ZSFG and also the hospital epidemiologist there, which has been a full-time job for the last couple of years. She has a number of important roles in CDC-related projects, including serving as the California principal investigator for a multi-site C. diff surveillance project. She's also a member of the steering group of the CDC's Healthcare-Associated Infections Community Interface. She's a member of the UCSF Academy of Medical Educators, is a Department of Medicine Master Clinician, and she has been regularly asked to participate in these kinds of clinical problem-solving cases, including for several publications in the New England Journal of Medicine. So Lisa, if you can turn your camera and audio on. There you are. Hello, nice to see you.
Hello, lovely to see you.
All right, you ready to get started?
I am. I am certainly hopeful that it will be fun and fun for the audience.
Before you start these things, like, what's your main thought? Is it excitement, anxiety? How do you deal with this moment?
Yeah, that's a great question. I would say there is always anxiety associated with it. My general strategy is to try not to think about it too much ahead of time, and then to hope that as the case starts to be presented, that you kind of settle down and just think about the case and go with the flow. And you just always hope that it's going to be something that you've heard of, as opposed to something that you have not.
Okay, well, I think we're okay on that. Okay, let's go ahead. You're among friends. It'll be fine. Let's go ahead and get started. A 24-year-old man with no known past history presents to the emergency department with a progressive headache and vomiting over the last 2 weeks. Review Systems is notable for 1 month of intermittent diarrhea, runny nose, and a cough, 1 week of decreased appetite, as well as fatigue, myalgias, and subjective fevers. Further history was limited by altered mental status. He was noted to be lethargic and confused. So we're going to give you a chance to weigh in a second, but let's do an audience question first. Which of the following causes of headache are you most concerned about? A, migraine, B, bacterial meningitis, C, a chronic meningitis, D, a bleed, E, an intracranial mass, and F, idiopathic intracranial hypertension. All righty, I think we can probably see the results there. All right, so we have 43% here most concerned about acute bacterial meningitis, with lesser group chronic meningitis, and about tie between intracranial bleed and an intracranial mass. Nobody likes migraine, and one person liked idiopathic intracranial hypertension. So let us go to the next slide and ask you what you think. And I'm happy to go back to the facts if you want us to see the slide again.
Sure, that would be very helpful. Thank you.
Okay, there we go.
All right. Well, as any good CPS case, this is starting quite undifferentiated. Which is good. So it would be helpful to cast a broad net. And it actually was interesting the way the question was phrased, because I feel like you could interpret it two different ways. You could interpret it as, what are you most concerned about in terms of what do I really not want to miss, like acute meningitis, versus what am I most concerned about? What do I think would be most likely in this scenario? I think what we always need to try to figure out when we're, kind of early on in the case is, is this all going to be covered by one entity? Is this all going to be united? So is whatever is causing this young man's diarrhea, runny nose, and cough, specifically associated with the fact that he's presenting with headache and vomiting? Or, could he have something else? Could he, for example, have had a, viral type illness that is now predisposing him, to something acute that has developed on top of it? Is it all part of the same process? So, in terms of 1 month of intermittent diarrhea, that's long for something, acute diarrhea in somebody, a healthy young person with no past medical history, that usually will have gone away. So, we do have these symptoms that have, been going on for some time, and then appear to be increasing now with subjective fevers, myalgias, fatigue, and decreased appetite. This could certainly be an infection. You also wonder about something like first presentation of inflammatory bowel disease in somebody who's young and whom we don't have past medical history as yet. But it's not immediately obvious why he has progressed to have headache, vomiting, and really profound altered mental status at this point. He, could have an abnormal GI tract, and something could have located through to the bloodstream that could now be causing a CNS infection. But I really feel like our differential at this point is quite wide, and we probably don't have enough information as yet to know exactly where we should be focusing.
Great. That's terrific. I like the way you frame concerning, really have to sort out, are you talking about most likely or most, or red flag, kind of the things you can't miss. Let me ask you a couple questions about it. Let's assume that the headache and vomiting has truly gone on for 2 weeks. Was that too long for this to be bacterial meningitis without him being dead?
Yeah, probably. With the possible exception of chronic meningococcemia, then progressing to meningitis, there is a syndrome of that. But in general, in a 24-year-old, the two most common bacteria that we would be thinking of would be either the pneumococcus or the meningococcus. In general, those are going to present over a much shorter period of time. So I think I don't want to miss it, but in terms of it being bacterial meningitis, it's not the highest on your list based on the time course.
Yeah. Good. And obviously you have to figure out whether the history is reliable or not, and you wouldn't want to hang your hat completely on the time course. Second thing, you made the point, sort of this is an Occam's razor versus Hickham's dictum thing. Is this all one thing or two things? That one possibility is this was a viral thing and has now morphed into a bacterial or a different kind of thing. I'm sort of familiar with that, like when we talk about a viral pneumonia, then a staph superinfection. But does that happen in other domains as well, where you have a viral infection that predisposes you to a second infection?
Yeah, so I think your description is the most classic. So, and I think the one that we would think about most commonly would be post-influenza, with either actually pneumococcus being the most common bacterial superinfection, and then Staph aureus also possible. But if you do have there may be other circumstances that are less common where you might see something like that. For example, could you have a more chronic infection going on in your GI tract that then is causing abnormalities in the mucosa, and then is predisposing you to have something translocate through into the bloodstream? Could that be seeding somewhere else? So I think that there are possibilities there, although those certainly aren't the most common presentations.
Right. And I'll make one last point, which is sometimes when I'm teaching the house staff or the students, that make the point that when someone has two different trajectories, meaning something was going on and then something else seems to have supervened, sometimes it's another infection, but sometimes it's the effect of the thing they did for thing one that's leading to thing two. For example, was he taking a medication for his URI symptoms that led to thing two? So first of all, do you think about that as well? And second of all, if so, is there a medication that might explain headache and vomiting?
Yeah, that's a great question. Certainly medications are always going to be high on the list of things that are, causing symptoms, once we get more information. And there are a variety of medications that can cause headache and vomiting. One of the ones you might think about early on would be NSAIDs, which can actually lead to a meningitis, and could certainly cause them to have headache and vomiting. Although I would not expect, in the context of, something like a meningitis caused by a medication, to have this profound lethargy and confusion, unless there's something else going on additionally.
Great. Okay, thanks. Let's go on. Okay, past history. Possible history of anemia in recent months, etiology unclear, no surgeries, no medications, no allergies, immunization, childhood vaccines he got, don't know about his COVID vaccination status. And have to ask, by the way, just, having lived the lives we've all lived the last 2 years, is there anything that sounds COVID-y about this at this point?
Well, I think we're increasingly appreciating, as an ID person, I've spent a lot of time talking about how TB can do anything and how syphilis can do anything. I think we're increasingly appreciating that COVID can do a lot of different things. And certainly, his initial cough, not feeling well, diarrhea, that could, sure, that could be COVID. And then, could he have had a clot, some kind of a complication that's now leading to him to have more of a CNS process? I would certainly test for COVID. He's going to get tested for COVID anyway, whether or not I put it on my list. So we'll have a sense of that. But I would not rule COVID out. But clearly, it would not be classic.
Got it. Okay, social history, a little geography lesson here from Minas Gerais, Brazil, and that's where it is. Relocated to San Francisco 4 months ago, living with a friend, sexually active with men, alcohol use minimal, substances none. So it's probably, the question is, does this change the DDX? I'm guessing there are probably a couple of thises. One is where he's from, second, that is sexually active with men, potentially. Mm-hmm. So why don't you go ahead and take that?
Yeah, absolutely. So we had already been starting really broad, but now I think we need to add a few other things that I might not have been thinking about initially with the first slide. So he has been in San Francisco now for 4 months, coming from Brazil. And so I don't think we have to be thinking about things that have a very short incubation period. And when we think about, he's reporting subjective fever, or we've got that in the history. But when we think about fever in a traveler, we kind of divide it into those things that have a short incubation period and a long incubation period. If what he has is related to something that he'd be more likely to get in Brazil than in the US, we're in the land of long incubation period, which people will talk about as being more than 2 to 3 weeks. And there are a number of things that can be in this category. Brazil, we would think about things, for example, like malaria, depending on exactly what his risk factors had been, and where he has been. We would think about paracoxy. Most of the cases of paracoccidiomycosis, which can reactivate. So we might think about those sorts of things, as well as a number of other things. Could he have leishmaniasis? There's a whole list of things that you might be more likely to get in Brazil than you would in the U.S. But I think one big question that we're probably going to want to answer right up front, given his sexual history and the fact that he's not giving us very much history, himself now, is whether this is a person who is living with HIV, even though we didn't get that diagnosis up front, versus not, because if he is immunocompromised, then we are going to have a somewhat different and longer list of things that may be on our lists, including opportunistic infections, perhaps certain malignancies that are going to be on our list that we wouldn't have. So I think that'll be a test that we'll want to get very early. The other thing that I'm thinking of, in somebody who's sexually active with men who has diarrhea, is whether he might have a pathogen that is commonly transmitted via that route. So we might think about Shigella, for example, which is more common in men who have sex with men. would not usually be causing you to have profound altered mental status, however. So we might be thinking about a few different things in those cases. And then Entamoeba histolytica could be causing a more prolonged case of diarrhea, could be causing a fever. Does he have invasive disease? Again, altered mental status, headache and vomiting would, that would not be the presentation I would expect with that. But, is there more than one thing going on here?
I seem to have a memory of like terrible amoeba like going to the brain. Does that never happen?
Well, so that is possible. I think you're probably thinking of either the ones like Naegleria that tend to happen relatively acutely, usually after water exposure. But there are other amoebae like Acanthamoeba and Balamuthia that are rare, but would be on your list and would be more common. Certain of these are more common in immunocompromised as opposed to immunocompetent hosts. Those are challenging diagnoses to make. Amoebae that present later on, often diagnosis made via brain biopsy.
And thanks. And so it sounds like a big branch point here is his HIV status. In terms of the non-HIV related infections that have long incubation periods that still could be from Brazil, even 4 months out, do any of them then present with meningitis, or is this a consistent presentation for any of those?
Well, I think that probably the one that we might think about that would be more common in Brazil, but not impossible in the US, of course, tuberculosis is going to be on our list, and that can have protean manifestations. And, this could be a person who is having a presentation of TB meningitis. Brazil, it probably falls into the category of being moderate risk rather than a high risk place. And again, disseminated infections are going to be more common in folks who are immunocompromised than those who are immunocompetent. Paracoxy of the dimorphic endemic fungi is not typically associated with meningitis, although I'm sure there are cases that have been reported. Of the dimorphic fungi, the one that we think about most often associated with meningitis is cocci. Mm-hmm. And of course, whatever he has does not have to be related to coming from Brazil. And he's been, in San Francisco adjacent to an area with cocci for some time now. So that's not off our list, but he's pretty profoundly ill for somebody who's presenting with a chronic fungal meningitis, but TB meningitis can, bad prognosis if you're presenting with this much altered mental status, compared to people who present earlier.
Right. And last question of for those of us who've forgotten the types of malaria and all that, and at 4 months out, if it's malaria, which one is it, and can it cause? I remember one of them can cause a bad CNS infection. Is that one that you can get 4 months after leaving an endemic area?
Yeah. So falciparum malaria is the one that tends to present earlier. Almost always presents within a month. And that is because you get more severe disease, tends to be most associated with the CNS findings. So that would be exceedingly unlikely. So the malarias that you would be thinking of, the more common one would be Vivax malaria. And it would cross your mind. Vivax malaria is typically associated with fever, and you can get some abnormalities in terms of your red blood cell count, the anemia. You can get some low platelets. It's not usually associated with CNS abnormalities because the presentation is not usually as severe. Mm-hmm. with severe disease, would be something that you would think about. And so if I were seeing this patient, I would be refreshing my memory about, specific infections, particularly from this region of Brazil, because as you said at the very beginning, nobody remembers everything. I am certainly in that category. So I would be refreshing my memory about what would be most likely.
Great. Okay, let's do a physical. He's got a fever, a little hypotensive, actually fairly hypotensive, heart rate 130, rest rate 22, 96% saturated on room air. So when more vital signs are red than black, there's a problem. You see exam, ill appearing, no oral lesions, tachycardic, tachypnic, lungs clear otherwise, belly's benign, no edema, neurolethargic, difficulty maintaining attention, able to state his name, inconsistently answering yes/no questions, grossly intact strength and sensation, skin is negative. Initial data, he's got a low absolute lymphocyte count with a white count of 5.6, hemoglobin 8.8, normal MCV, and platelets 97. Some additional labs, you see them here, NI-GAP of 16, potassium 6.1, BUN 152, creatinine of 14. VBG, acidemic 7.3, CO2 29, normal lactate, coags normal, liver studies, lipase normal, UA, proteinuria, blood 6 to 10 red cells, no white cells, COVID negative, at least on PCR. Here is a non-con head CT, patchy hyperdensity within the bilateral basal ganglia with extensive surrounding vasogenic edema, left greater than right. All right, a lot of information. Happy to go back and look at it, any of it with you. What parts you want to go back to?
Yeah, well, there is a lot there, and maybe we'll just start very briefly with the physical exam, if you don't mind going back to that. So I would say that the key thing about the physical exam is that you are worried that whatever is going on, we are. I mean, I think we were already worried because it's a worrisome presentation to have profound altered mental status, especially in a 24-year-old that we didn't have any prior past medical history. But certainly the abnormal vital signs, the hypotension, and his lethargy on exam are concerning. But there's actually nothing here that is super specific or localizing, I would say. I'm always thinking in these cases about looking in the mouth and looking at the skin to see if there are any lesions that may be helpful. So this is confirming that we're worried, but I don't think it's giving us a lot of specificity, and so we're going to be casting a broad net in terms of our initial diagnostics. And then, would you mind going forward to his labs? I'll just point out a couple of things here. He does have a low lymphocyte count. We can see a low lymphocyte count and a relatively low white count in a variety of settings. But with that very low lymphocyte count, we'd already mentioned it would be helpful to get an HIV test just to know, because that is going to change our management and what we're thinking. So we'd still like to get that. But we can see low lymphocytes in other circumstances, for example, in the setting of sepsis, although usually when you have a low white count in the setting of sepsis, it may not be so skewed in terms of the lymphocytes being disproportionately low. But then, I mean, the thing that is just like jumping out at you is his creatinine is incredibly elevated, 14.3 with a BUN of 152. He has an anion gap, a modest anion gap acidosis, and he's got some hyperkalemia. So, this is a really, really high creatinine for acute renal failure. So I am wondering if this has been going on a little bit longer, perhaps in conjunction with the, illness he's been having over a month. Be good to get some more information, but and certainly it could be acutely worse because of hypoperfusion, sepsis, being ill. But I'm struck by the fact that that is a very high number. So we're certainly quite worried about his renal failure, wanting to manage that, and then wanting to get more information about what might be going on. It's good that we have a urinalysis. He's got proteinuria. He's got some blood. He doesn't have a lot of white cells there, but I suspect he is going to need further workup in terms of imaging, and perhaps we'll be thinking about a renal biopsy.
Are you inclined to package the renal failure with the syndrome, that he's got some syndrome that includes renal failure and a CNS? I mean, we'll get to that thing in a sec. So, or are you inclined to say the renal failure might just be secondary to him being septic and he's got ATN, and it sort of doesn't package itself together as one neat diagnosis?
Yeah, so I don't as yet have a neat diagnosis. Putting all these things together under one framework. I am concerned, though, as I said, that the renal failure might have been going on longer than you would have expected for this, kind of acute abnormalities with hypotension and fever. So we may be seeing something that's more related, a more chronic systemic infection, perhaps. Could this be a malignancy that is affecting multiple systems? That is something that would cross your mind. And then you have kindly brought us to the non-contrast CT of the head, which is very worrisome. I think probably everyone in the audience is thinking that they are going to want a bit more imaging here. Ideally, I think an MRI to characterize it better, or if that's not immediately available, a head CT with contrast to get a better sense of what's going on. But it does look like he has something distinctly and not subtly abnormal going on in his brain.
Okay, we'll find out some more. But it sounds like you're now worried about some primary CNS process, but not exclusively infectious. There could be other things that could cause something that might look like this.
Mm-hmm.
Okay.
Yeah.
All right. You've been asking for it for a while, and finally we will give it to you that he's HIV positive with a viral load of 790,000, CD4 count of 53. Hepi negative, C negative, RPR non-reactive, quantiferon negative, 3-site GCCT negative. That part, I actually don't know what that means. Interesting. And here is, I believe this is MR, or is it a CT with contrast? But it looks like an MR, I think.
It's like an MR.
Yeah. And there is a reading: extensive confluent T2 flare and edema centered around the basal ganglia, anterior corpus callosum, and frontal deep white matter. Additional extensive scattered supra and infratentorial non-contiguous lesions with T2 flare signal. There it is again.
Ooh. Okay. I can do the easiest part first. The 3-site GCCT negative just means they screened him for gonorrhea and chlamydia at 3 sites, and that they're negative.
Got it. Thank you. Appreciate that. 3 sites in his body doesn't mean he goes to 3 different places, right?
Correct.
Got it. Okay, thanks. All right. And then, okay, you've been asking for HIV and sort of treated it as something of a branch point. So we've now reached it. So now, based on what you now know him to be positive with that viral load, what does it make you think? And then the interpretation of what's going on in his brain, how does that change?
Yeah, absolutely. So, one of the most helpful things here, getting this result back and then seeing a CD4 count of 53 with a percentage of 8, so profoundly low, is that I need to, as we're thinking about this, it would be most appropriate to not hang our hat on trying to tie everything together with one diagnosis. Because patients who have low CD4 counts, and presumably this seems to be a new diagnosis of HIV since we were not getting a history of it before. He has a high viral load. He's not on antiretroviral therapy. So he could be presenting with multiple opportunistic infections. He's not limited to just one. He could have an opportunistic malignancy, most commonly lymphoma. And he can have as many of these things as he has. We're not limited to a specific number of them. I'm happy that he had a QFT, a quantiferon, that was obtained, and it's somewhat helpful that it's negative. But just to point out that particularly in a profoundly immunocompromised host, you can have a negative quantiferon test and still have active TB, including disseminated TB. So it doesn't rule it out, but if it were positive, then it goes up on your list. And then, just in terms of the MRI of the brain and what we're going to be thinking of in someone who has HIV with a low CD4 count. So, it's always dangerous to ask someone who's not a radiologist. And, we're so lucky that we have amazing neuroradiologists to interpret. So my differential is not going to be nearly as good as the differential diagnosis of our neuroradiology colleagues, who, of course, we will be huddling around the study to get their insights. But do you maybe want to bring up the scan so we can look at it together? Great, thank you. So, as I look at this and hear about the read, it does look like there are multiple areas that are abnormal. The basal ganglia and the corpus callosum are involved. I would actually want to go through multiple images, again, with the neuroradiologist to know if it is enhancing. Because, kind of the top 3 things that we're going to be thinking of are toxoplasmosis, primary CNS lymphoma, and PML. And these, and particularly toxo and primary CNS lymphoma, have overlapping imaging findings, but there can be some subtle distinctions that our neuroradiology colleagues can help us out with. But both toxoplasmosis and primary CNS lymphoma, when you look at them, they appear to take up space on the scan, and they are almost always enhancing. We classically think of them as being rim enhancing, but we would expect to be seeing enhancement. PML is a little bit different. So PML is, asymmetrical, affecting somewhat different areas of the brain, especially the white matter, and should typically not be enhancing or space occupying. For toxo, there's almost always multiple lesions. primary CNS lymphoma can either have multiple lesions or just one lesion. So if you see just one space occupying lesion, you're thinking lymphoma is higher. If you see multiple ones, those can both be on your list. So all three of those things I'm going to be thinking very highly about. I'm going to want to get
why don't you hold off and tell us what you
yeah.
want, because I will ask the audience that in a second.
Okay, I'll be quiet.
Perfect. All right. So let's, case continued. Had been started on empiric coverage for meningoencephalitis, vancomycin, ceftriaxone, ampicillin, acyclovir, steroids deferred, hypotension, tachycardia improved, LP, 0 red cells, 3 white cells, 88% lymphs, normal opening pressure, normal glucose and protein, a bunch of viral studies, CRAG negative, EBV PCR is positive, cytology increased mature lymphocytes, decreased CD4 to CD8 ratio, flow cytometry, paucicellular, and felt to be non-diagnostic. So let's ask the last audience response questions. What next steps might you consider at this point? You see the choices. You can get basically a CT of his body. You can get a PET CT, you can get a repeat LP, a brain biopsy, bone marrow biopsy, or start him on high-dose steroids. Let's get the poll up if we can. I don't see the poll on my screen. Is there? Lisa, can you see it?
No, I don't see it.
All right, we must be having technical problems with it. Go ahead, there we go. All right, go ahead and vote. Okay, we can quit. And half the people want a brain biopsy. Next choice is a pan scan, and a fewer people want a bone marrow or a PET CT. How about you? What do you want?
Well, if I'm allowed to ask for things that are not on the list, perhaps I missed it, but I would definitely want a toxoplasmosis serology, because CNS toxo is going to be, only even in advanced HIV, where people don't have normal immune systems and antibody production may not be normal. Only a very tiny percentage of folks who have CNS toxo will have a negative serology. So a negative serology is very helpful in making that go way down on your list. And then in terms
let me just be sure I understand, Lisa. Positive is diagnostic or not so much?
So a positive is not diagnostic, but a positive with characteristic imaging may lead you actually, it's one of those things in medicine where there is a well-described pathway to do a therapeutic trial, where for about 2 weeks you will give antitoxoplasmosis therapy and monitor carefully for clinical improvement, because almost everybody who has toxo who's going to improve with medical management will be substantially improved both clinically and radiologically after about a 2-week period. So if the serology were positive, you could think about that, which might spare invasive procedures like a bone biopsy.
And the fact that there were so few white cells in the LP, does that help you with toxo?
It does not help you very much, because we got a whole bunch of stuff back that I think was pretty helpful. So it really does not look like he has cryptococcal meningitis. I didn't mention cryptococoma as causing this. That would be giant there. But again, he can have more than one thing. So he could have had cryptococcal meningitis, along with something else causing a mass lesion. But the CSF and probably serum CRAG being negative, those are very helpful. That also helps us because that's one of the contraindications to starting antiretroviral therapy right away. So that's a super helpful test to get. In terms of the EBV PCR being positive, that is suggestive of a primary CNS lymphoma in this setting, but that is not a perfect test. It doesn't have perfect sensitivity or specificity, but it does move the needle. And so having a positive EBV PCR does make you concerned that this could be primary CNS lymphoma. That actually does not explain all the other things that are going on. It doesn't explain why he's presenting with hypotension and profound renal failure and all the other things, but I am worried, given the appearance on the MRI and that value, about primary CNS lymphoma. We don't seem to have a JC virus, which I think was probably sent, even if they didn't think the imaging was classic for PML, because that's actually a pretty good test for PML. And again, because a brain biopsy can be associated with morbidity, would be helpful there. So I would be curious, about all of those things.
Okay, so let me move on because I want to be sure we get to the discussion. And I think we got everything for you except for your toxo test. So here's what happened. Initial non-diagnostic LP. A second one was performed, same as prior in terms of the cytology pressures. VDRL negative, RPR non-reactive, JC DNA was negative, repeat EBV positive, 20,000 copies per mil. And oncology felt that the imaging and bland LP findings were concerning for, but not diagnostic of CNS lymphoma. Brain biopsy was considered, but thought to be highly morbid. Additional discussions about a third LP. Meantime, the patient had started on hemodialysis for oliguric acute renal failure, workup muddy brown cast, normal C3, C4, ANA, ANCA, kidney biopsy, focal sclerosis, sclerosing GS with 50% scarring, consistent with HIV-associated nephropathy. With consent, he was initiated an antiretroviral therapy with those medications. On hospital day 15, a code stroke was called for unresponsiveness and decreased lower extremity strength. And you see there the progression of his CNS illness with some more compromise of his ventricles. And there's his MRI that day. Marked interval increase in size and mass effect of his multifocal supra and infratentorial masses. Masses in the basal ganglia resulting in third ventricular compression and early hydrocephalus. So that's the point that we'd love to ask you what you think the final diagnosis is.
Okay, well, so I will just say, it's always dangerous not to agree with our wonderful oncologists, and I think I will have to agree with them here that primary CNS lymphoma does seem to be the most likely cause of the mass lesions in the CNS. It would not be dissuaded by the negative cytology result, because cytology is unfortunately usually negative. There are a few things that people try to do to nail down this diagnosis without doing a biopsy. The classic one that was talked about as early as the 90s was doing a thallium SPECT study, because you will expect to get high uptake with primary CNS lymphoma, and PET-CT has sometimes also been used. But my guess is that the presumptive diagnosis here was probably primary CNS lymphoma in the setting of advanced HIV.
Great, thank you. Case was urgently discussed with ID, neurology, oncology, decision made to treat empirically for CNS lymphoma without biopsy. Started on pulse steroids as well as Ritux. ICU course complicated by tumor lysis syndrome. I guess that means there's a tumor. Mental status improved to baseline over the next 3 to 4 days and transferred out of the ICU, which is impressive when you think about how sick he was. And so the final diagnosis made based on all of that is HIV/AIDS complicated by primary CNS lymphoma and HIV-associated nephropathy. So as we said, getting it right is not the main goal, but you did, so thank you and congratulations. Let us bring on Natasha Spottiswoode, who's an infectious disease fellow, who's going to give us a short talk on this entity and how to think about this case. And then Lisa, I'll bring you back again at the end for some final comments.
Thank you so much, Bob. Can everyone hear me okay?
Yep.
So first of all, thank you for inviting me to join you. I'm just going to share a couple learning points relevant to this case. I'm going to start by talking about my approach to CNS disease in people living with HIV, touch on HIV-associated malignancies, and finish with a brief discussion of HIV-associated nephropathy. So first of all, when I'm thinking about CNS disease in someone living with HIV who has CNS disease, my first step is to ask how immunosuppressed they are. So if this person is not immunosuppressed, if they have a high CD4 count, if you could give us a click, Bob, then a high CD4 count and a low viral load, I'm thinking about them as having a lower probability of opportunistic infections. If, however, they have a low CD4 count and a high viral load, then my next step, as Lisa so said, is to talk to my neuroradiology colleagues. And the question that I'm asking them is really, is this a space-occupying lesion or a not space-occupying lesion? So space-occupying lesions, as shown here, are things that are physically displacing the brain tissue. And my top differential for someone living with HIV who's immunocompromised are CNS lymphoma, toxoplasmosis, a pyogenic brain abscess, and in the right clinical context, rarer entities such as a tuberculoma, cryptococcoma, Chagas disease leading to a chagoma, or others. If this is a non-space occupying lesion, I'm thinking about something that changes the appearance of the brain cells, but does not sort of shift them out the way. And those are mostly viral. So PML as caused by the JC virus, CMV encephalitis, and HIV encephalopathy. Now, once I'm in the world of a person who has HIV, who is immunocompromised and has a space-occupying lesion, my top differential is lymphoma, toxoplasma, and a brain abscess. And then the next steps are firstly to seek additional diagnostics and to start empiric therapy. So going through sort of the top 3 diagnoses, as Lisa outlined, the top ones are lymphoma, toxo, and a brain abscess, and those have different diagnostics and therapeutics. For CNS lymphoma, the gold standard is going to be brain biopsy. Sometimes, as in this case, it's not possible to do that for safety reasons. And then CSF cytology can be tried, but also, as Lisa said, it has poor sensitivity. It's about 15% per tap. EBV virus in the CSF by PCR is suggestive but not diagnostic of CNS lymphoma, and I will talk about why shortly. And therapy is going to be first-line methotrexate, but that is precluded in people with renal failure on dialysis. And so he received rituximab and steroids. Toxoplasmosis, which is a parasitic infection, is also very common and radiologically is hard to distinguish from lymphoma. Diagnostics for that include serum IgG, which, if positive, raises the pretest probability, but is not diagnostic. And that's the reason why we always ask for a toxo IgG when someone is newly diagnosed with HIV. Toxoplasma PCR from the CSF, again, suggestive, but not fully diagnostic. And this is one of the diseases for which you don't necessarily need a brain biopsy. In the setting of a positive IgG and imaging findings that are highly consistent, most people will try a therapy trial, which is sulfadiazine, pyrimethamine, and leucovorin as a first line, a second excellent line being high-dose Bactrim. The last thing you want to think about, because it's so morbid, is a pyogenic brain abscess or a brain abscess that contains fungal or bacterial organisms. Gold standard there is talking to your neurosurgical colleagues to aspirate the lesion and send for culture and molecular diagnostics. So I just want to take a second and talk more broadly about HIV and why it is associated with malignancies. People living with HIV have higher rates of many cancers versus the general population, with the 2 major buckets there being cancers that are associated with smoking, such as lung cancer, and also cancers that are associated with oncogenic viruses, such as human papillomavirus-associated anal and vaginal cancers. I also just want to bring up the fact that this was noticed really early in the pandemic. If I could just get a couple clicks, Bob. Some of the earliest reports from this were actually reported in San Francisco in 1989, noting a very high prevalence of lymphoma in people who were severely immunosuppressed. Some of these cancers, which we consider to be associated with very severe immunosuppression, are considered AIDS-defining conditions, such as CNS lymphoma. Now, the first reports of this may have been in 1989, but the landscape of cancer in people living with HIV has changed profoundly. This graph is from a recent NEJM review looking at cancer in people living with HIV. The sort of light yellow here is these AIDS-defining cancers, such as CNS lymphoma, and the sort of redder color is non-HIV defining cancers, such as lung cancer. And what you can see is that over the 15 years, the prevalence of cancers that are associated with very severe immunosuppression has decreased, and the prevalence of those which are not has increased. And this represents people living longer with HIV thanks to the advent of highly active antiretroviral therapy. So when I was learning about this case, I asked a really basic question, which is why is HIV and AIDS associated with malignancies? And the answer is quite complicated, but it has to do with the lack of control of oncogenic viruses. So various human herpes viruses, such as EBV or Epstein-Barr virus and HHV8, infect most people chronically and can be oncogenic or cancer-causing or cancer-contributing. And in people who have very dysregulated immune systems, these viruses lead to a greater preponderance of specific tumors. A big bucket is non-Hodgkin lymphomas, which includes CNS lymphoma, a group of entities known as Castleman's disease, which present with diffuse lymphadenopathy, and a rare and aggressive cancer called primary effusion lymphoma, which shows up as effusions along the serosal surfaces, such as the pericardium, the pleural linings. We have mostly learned about Kaposi sarcoma, which is also associated with HHV8, presents with classic red and purple skin lesions, but also can affect the lung or viscera. And finally, one other that's included in this group is highly invasive cervical carcinoma, which is linked to the human papillomavirus virus. I want to finish by talking about HIV-associated nephropathy very briefly, and first say that this is a rare entity. Most cases of AKI and end-stage renal disease in people living with HIV are not due to HIV-associated nephropathy. It's something that's very much associated with high HIV viral load. It has an association with West African ancestry, but it's very important on the differential to rule out more common causes of AKI, such as sepsis, ATN, medication effect, and to rule out end-stage renal disease due to comorbid conditions such as hypertension, diabetes, hepatitis C co-infection. It has an association with APO1 gene variants that we're still trying to understand, and pathology will typically show this pattern of collapsing and scarring FSGS, as in this case. The clinical picture of a patient with HIVAN is someone who's living with a detectable viral load, who has proteinuria, as this patient did, and who has echogenic kidneys by ultrasound, as this patient did. Definitive diagnosis is made by biopsy. You'll want to include your ID and renal consultants early, but treatment is prompt initiation of antiretrovirals, a controversial and complicated role of steroids, and an ACE inhibitor sometimes to control proteinuria. I just want to finish by reflecting that caring for this patient was a very multidisciplinary process, and I'm really grateful for the providers from MICU, medicine, neurology, oncology, renal, neurosurgery, and interventional radiology teams who helped to take care of this young and critically ill patient. I've called out a few here below for whom I have particular gratitude, but everyone contributed to this case, and I'm very glad that we were able to get him more stable and on a better path. Thank you all so much.
Thank you, Natasha. That was fabulous. Let's bring Lisa back and give you an opportunity to have any final reflections you have on the case. I have one question, which is, he looked awfully septic. Do we think, can we explain his septic appearance when he came in based on either his lymphoma or his renal disease, or did he have a third thing going on?
Well, I suspect we'd have to ask Natasha if there was something else going on. I don't think we heard anything specific in the presentation that would necessarily have explained it.
Natasha, any comments?
Yes, he did actually also have salmonella bacteremia, which we omitted for reasons of clarity.
All right. And was a toxo test ever sent?
It was. His serum toxo was actually negative. The PCR from CSF was not sent due to limited quantities.
Got it. All right, thank you. That was great. Lisa, any final reflections on the case?
Well, I just want to say, first of all, Bob, I want to say thank you so much for inviting me. Natasha, thanks so much for those fantastic teaching points. And maybe just to finish up to say, you know, in now with antiretroviral therapy, you know, in this era, the prognosis for primary CNS lymphoma is much better. You know, is much more common that we were seeing this in the 90s and the patients didn't do well. And now they're actually doing much better, although I don't know exactly what his prognosis will be if he can't get the first line therapy due to his renal disease. But so glad that, you know, he's in care now and got started on ART.
And is his renal disease, is it possible it will improve with therapy, or once you have end stage or this level of renal failure, you're stuck?
Yeah, well, I'm a little worried that he may be so advanced now with this creatinine elevation that he may not improve. But folks do improve with antiretrovirals, so another indication to go ahead and get it started. But Natasha will have the definitive answer on that.
Yeah.
Yeah, unfortunately from our renal colleagues, we learned that in the early stages, it can be reversible, but he's now reached the point that a lot of his glomeruli in the kidneys are quite scarred down. And so they think that renal recovery is unlikely.
Got it. Okay, well, thank you both for a fantastic discussion, really interesting case. You know, fortunately, not the kind of thing we see that often today. And in the old days, we saw this all the time, or things like it. And with effective therapy, we usually don't. But this is a reminder that it still can happen. And thank you both for a fabulous discussion. Thank you, Fangdi, for putting the case together. Please tune in next week. We'll do another COVID Grand Rounds.